Okay, so why don't we go ahead and get started. So today's topic is latest advances in CMR techniques and future applications. And so this is really going to be kind of a little bit of a whirlwind tour of some kind of recent advances and then also kind of a look at the direction that the field is headed into. And so obviously, I think, I want to take us back a little bit in time because I think, the late gadolinium enhancement CMR is really the one technique I think that has really propelled CMR from kind of a research tool to one that has widespread clinical application, because this has really opened up a lot of different avenues of investigation. And obviously, I think we're all aware of the fact that this late gadolinium enhancement technique is really ideal for visualizing myocardial injury. And as is shown in this 1999 initial publication, it can give you kind of an exact match of what myocardial infarction looks like. And this is an example in a animal model with ligation of the LED. And over the last 15 years or so, there's been studies showing that there's a pretty close relationship between the likelihood of improvement in contractility and the transmural extent to hyperenhancement. And in this publication, this was looking at improvement after revascularization, either percutaneous or surgical. And notice on the right-hand side, for those segments that showed greater than 75% hyperenhancement, the likelihood of improvement was very, very low, essentially close to zero. And furthermore, this technique seems to perform quite well even in the setting of significant wall motion abnormality. So if we look just at the akinetic or dyskinetic segments, both the positive predictive value actually gets stronger and the negative predictive value is essentially 100%. So, I think that obviously the way that this technique is done, we insert a peripheral IV, patient goes into the scanner, we acquire a full set of cine images, then give gadolinium contrast, wait about 5 or 10 minutes, and then do our delayed enhancement MRI images. And you'll notice what's unique about the viability or scar assessment by CMR is that there's no stress agent that's required to do this. And in addition to revascularization in the setting of chronic coronary disease, there's also data showing the same inverse relationship in the setting of acute CAD, so patients where you're looking at myocardial stunning, and also in the setting of chronic heart failure, where you're looking at patients just getting simply treated with medical therapy. And these are patients that were not revascularization candidates, or they were patients with non-ischemic cardiomyopathy. And in all cases, you can see that as you have less viable myocardium within any given segment, the likelihood of improvement gradually gets lower and lower. And you will notice, obviously, that in the setting of chronic heart failure, where you're just getting medical therapy, the likelihood of improvement overall is shifted downward. And that's not a surprise. We know that restoration of blood flow is going to be certainly more effective than any mechanical or any medical therapy. So let's move on to look at some kind of special situations where this technique, I think, can be useful. And one of these, obviously, is in patients who have myocardial thinning. And so, the traditional paradigm had been that if you have myocardial thinning, that should be equated with the presence of myocardial scar or infarction. But in fact, if you look at this example case here, where you have really a large area of wall thinning all along the anterior wall and apex. But when you look at the late enhancement CMR, you find that there's only a small area of hyperenhancement. So there's really a limited amount of scar, despite the fact that you have very extensive wall thinning. And in this example, what's interesting is that how often does this actually occur? So, we looked at this in a cohort of over 200 patients. We found that this phenomenon, where there's thinning, but yet limited scar, less than 50% of the wall thickness, occurred in about 18% of the patients within this cohort. And in fact, although there was some relationship to wall thickness, there really was a lot of scatter, suggesting that simply looking at wall thickness alone to try to identify the presence or absence of limited scar was not very useful. And then furthermore, in those patients that went on to get revascularized, what we found was that there was actually improvement. Let me see if this is playing. there's actually improvement in contractility. And if you look at that anterior wall that was akinetic before, now you can see it's actually started to improve contractility. And if you look at the EF, went from 30% previously to 50% after revascularization. And again, this is despite the fact that you had wall thinning, significant wall thinning, with a wall thickness of only about 4.5 millimeters. And in fact, that 50% cutoff seemed to perform fairly well in the sense that most or patients with wall thinning who had less than 50% enhancement within the thinned area, they all seemed to show improvement in regional systolic wall thickening, whereas for those patients with more than 50% thickening or more than 50% scar within the thinned area, essentially none of those patients showed any significant improvement in contractile function. And then furthermore, not only do you see a change in contractility, but I think what's more impressive is if you look at the thickness of the wall before revascularization and the thickness of the wall after revascularization, you can see the wall actually goes from being about 4.5 millimeters to now being about 9 to 10 millimeters. So you've actually recovered wall, or you've caused a recovery or reversal of wall thinning as well. And in this study, we also demonstrated, in fact, that for those segments with limited scar, or those patients that had limited scar within the thinned area, there was actually reversal of wall thinning in these patients. But those with extensive scar, more than 50% within the thinned area, did not demonstrate any recovery of wall thickness. And so I think this identified one specific subgroup where CMR may be useful is in patients with wall thinning, where it can help you in identifying the cohort of patients who have limited scar present and potentially identify a group of patients that may have reversible myocardial thinning. Now, let me move on to another kind of newer technique in CMR. And the idea here is that when you do delayed enhancement CMR, what you're trying to look for is areas of hyperenhancement, high signal in relation to normal myocardium. Now, one of the challenges, obviously, with this, and this kind of shows us how this technique is done. So you apply an inversion pulse, things recover, and you want to time your acquisition such that your normal myocardium is at zero magnetization, and therefore infarct is going to be higher than that, and therefore would appear brighter. Now the challenge obviously is that the blood pool also has a significant amount of contrast in it as well, and so the blood pool also has fairly fast recovery, and so sometimes it can be hard to differentiate a small area of enhancement within the subendocardium from adjacent blood pool. And so that's where a newer technique came along. So what we do right now kind of typically is we say, okay, well, let's wait a while. If we wait 15 or 20 minutes after we give the gadolinium injection, you'll notice that the infarct tends to hold on to contrast, but the blood pool, the contrast in the blood pool gradually starts to fade away. And so that's kind of the standard technique that we try to utilize is wait, 15, 20 minutes to try to get the blood pool signal to go down. But there's now a newer technique which is called a dark blood delayed enhancement, where by applying a special preparation pulse, you actually cause the signal in the blood to go away. So therefore the blood now appears black, so you don't have this issue of having to wait. Or if you did imaging early, you may have a hard time identifying is this truly an infarct or not. Now the blood is black, and so you can very clearly appreciate that there's a subendocardial infarct present here. And I'll show you another example. If you look at just the left-hand side image, and if your tech had, was doing the scan very fast and they're very proficient, and they blow through the delayed enhancement very quickly, you look at this and you say, okay, is there a subendocardial infarct or not? I mean, the wall looks thin here, right? At least the black area looks thin. And so oftentimes we would compare against the cine image and say, hey, on the cine the wall is much thicker than the black area here. But now with this dark blood delayed enhancement, what you're effectively doing is, and this is actually just kind of showing nicely the schema here, where if you look at the signal to noise across these pixels from the epicardium all the way in, you can see in both techniques, the standard delayed enhancement or this new dark blood delayed enhancement, you initially have very low signal to noise, meaning the myocardial signal is nulled because you have normal myocardium. And then as you get to the area of the infarct, the signal goes up in both techniques. But the advantage, obviously, is that with the dark blood delayed enhancement, once you get into the blood pool, the signal starts to go down again within the blood cavity, whereas with the standard delayed enhancement, the signal is still fairly high within the blood cavity. unless you wait a prolonged period of time. So, and again, this is something that's relatively new, just came out within the last couple of years, but I think this is a technique which is going to help us both for improved identification of subendocardial infarcts, but also, interestingly, if I showed you this image here, and I guess I gave away the answer down here, but if I showed you this image here, you'd have a hard time saying, yes, is there a papillary muscle infarct present or not? But if you look at the dark blood image that's performed, again, because the blood pool is black, you can very nicely appreciate that there's an evidence of hyperenhancement within both papillary muscles in this example case, or in this other case here, you can see that it's more confined to the posterior medial papillary muscle. And so this technique may be very helpful in the future in trying to look more closely at papillary muscle infarction, which again, we could identify to some extent previously, but I think this makes it much, much easier and more clear to identify. Now, the other thing though, what I've showed you up till now, whether it's the standard delayed enhancement or this dark blood delayed enhancement, these are all techniques that work on the principle of what we call a relative enhancement. So you identify an area of normal myocardium, and then you see areas that show more contrast uptake than an area of normal myocardium. And the reason that this works, both in the setting of acute infarct as well as in the setting of chronic MI or non-ischemic scar, is the fact that the underlying pathophysiology is based on the kinetics of gadolinium. So gadolinium is an extracellular contrast agent. That means it doesn't go into the myocardial cells that have an intact cell membrane, but actually just distributes within the extracellular compartment. So what happens in the setting of acute MI, you now have rupture of cell membranes, so gadolinium can enter into the myocardium. So within any given pixel, there's now a larger volume of distribution for gadolinium. Therefore, there's more gadolinium uptake within a pixel of acutely infarcted myocardium. And then if you look at chronic MI or non-ischemic scar, where you have more of a collagen scar matrix, you also have increased extracellular space. And again, the gadolinium goes into the extracellular space, and therefore you'll see hyperenhancement both in the setting of chronic MI as well as acute MI. So although they're very fundamentally different pathophysiologies, again, the kinetics of gadolinium work to your benefit that you can identify in both scenarios. And so really, the way I think of all of the late enhancement techniques are really that they're imaging the absence or reduction in viable myocardium. Now, the question though becomes, what about when you have patients who have very diffuse interstitial myocardial fibrosis, so that there's no normal region? Because the challenge with the late enhancement technique is you need to have a normal reference area that you null, and then you're looking to see if there's a relative increase in contrast compared to a normal area. And then what if you have spatial heterogeneity in the amount of interstitial fibrosis? So that's where, and we know that this is not an inconsequential thing, that in fact, in the setting of ischemic cardiomyopathy, roughly half of the extracellular matrix expansion that occurs is actually diffuse, not focal. And so that's where there's now these newer techniques. So the old technique, or the original technique, is this late gadolinium enhancement, which looks for replacement fibrosis. These newer techniques now allow you to identify diffuse interstitial fibrosis by using a methodology called extracellular volume fraction. So the way that this works is you're actually computing the absolute T1 value. And so there's newer techniques that we can utilize that are fairly rapid that allow, basically, instead of just doing one sampling after an inversion pulse, you're actually doing a series of different samplings after an inversion pulse is applied at slightly different time intervals. And that allows you then to identify what the signal is at each of these different time intervals after you apply the inversion pulse. And from that, you can do a curve fitting algorithm to determine then what the rate of T1 recovery is of any given pixel, right? Now, obviously, this requires that you don't have motion or arrhythmias that happen in between, and there's techniques that are employed using motion correction to try to get around this. But essentially, this allows you to, on a pixel-by-pixel level, to identify what the T1 is of each individual pixel, and therefore, you can identify what the T1 is of myocardium, and you can identify what the T1 is of the blood pool. And then you can do that before contrast to find out what we call the native T1, and then you can do that again after you give contrast to find out what we call the post-contrast T1. And then what you're essentially doing when you compute the extracellular volume fraction is by looking to say what is the change in the relaxivity, so 1 over T1, between, let's say, the myocardium before contrast versus the change after contrast. And obviously that's going to be related to the amount of gadolinium gadolinium uptake that there is by pixels within the myocardium. And then you can do the same technique, or you can do the same thing for the blood pool. So you can say, what's the T1 of the blood pool before contrast, and then once I give a gadolinium contrast, what is the T1 of the blood pool now? Now, so since we know that the gadolinium is an extracellular agent, the amount of gadolinium that there's going to be in any given area is directly related to how much extracellular volume there is. Now, in the blood pool, we can actually determine what the extracellular volume is. And how do we determine that? Right, so we know that basically blood is really composed of red blood cells and extracellular space. So if we know what the hematocrit is, then 1 minus the hematocrit will be whatever the percentage of extracellular space there is. So you can essentially see what the signal intensity change is for the blood pool, and if you know what the hematocrit is, then you can then solve to determine what, and you know what the signal intensity change is for the myocardium. You can use this to solve to say what is the amount of extracellular space within the myocardium. And that's the way that this technique works. And so this extracellular volume fraction, or ECV as we call it, technique has actually now been validated both in histologic studies in mice. There's also been human studies, both in excised transplant hearts, as well as in patients with AS or with hypertrophic cardiomyopathy undergoing septal-reduction therapy, where they did biopsies of the myocardium and correlated that with extracellular fraction volume, or extracellular volume fractions that were obtained by CMR beforehand. And then there's also some data from MESA cohorts showing that, in fact, there is a gradual progressive increase in extracellular volume fraction with age, as there is more kind of fibrosis deposition that occurs with aging. And then furthermore, this was a study, I think we skipped past this, I must have hidden that slide, but this was a study out of a group at Pittsburgh which actually looked at the utility of this in identifying prognosis, and it showed that patients with the highest tertile of extracellular volume fraction, highest ECV, had a worse outcome compared to patients with the lowest tertile of extracellular volume fraction, and that there was a relationship with the amount of extracellular matrix deposition or increase measured by CMR and short-term mortality in these patients. Now, so I think the kind of the take-home message with these newer ECV mapping techniques is that they're able to give you a surrogate for diffuse interstitial fibrosis that's beyond what we can see with the standard late gadolinium enhancement CMR techniques, and that this also seems to be associated with adverse outcomes. And then I think the future applications for this could be that this may be useful in looking at novel therapies that are geared to try to reduce interstitial fibrosis. Okay, so let's move on now. So one of the other challenges I'm going to talk about, and obviously the big limitation with cardiac MRI is the fact that for a lot of the acquisition, the patient has to hold their breath, right? So it typically requires a 5 to 10 second breath hold, depending upon the specific technique that you're looking at. And so this was actually a group out of the NIH that's been working on this now for the last 7 or 8 years. The idea being that could we get low resolution images? So the way that a normal MRI, a normal city MRI is done, we actually acquire high-res image by sampling over multiple different cardiac cycles and then stitching that information together in a way called case-based reconstruction to actually then generate a high-res image. So the idea here was, could we actually instead do low-resolution sampling, but then reconstruct the data over multiple separate acquisitions, so without having to hold the patient hold their breath, and register these images by doing a motion correction technique, and then reconstruct a high-resolution image. And so this is kind of some busy slides which basically show you effectively this, right? Which is that you can start out with, instead of just obtaining one low-res image, you can obtain a series of these, but again, while the patient is free breathing. These are what we call real-time or free breathing images, but then you can actually retrospectively reconstruct these, and you can see that you can generate a high-res image, which is similar to what you could generate by having the patient hold their breath. And so I'll show you two example cases here. And if I didn't put the label up here, I think you'd have a hard time being able to tell which is the one where the patient did an 8-second breath hold versus the one where it was just a free breathing acquisition that was then motion corrected and then regenerated into a high-res acquisition. But in fact, you will notice if you look closely, there are some subtle differences. On the right-hand side image, for example, if you look at the papillary muscles and the trabeculations, you're not quite able to see them as well, especially in the RV, as you are in the high-res breath-held acquisition. But again, the advantage here is that this is done with free breathing by taking multiple separate free breathing acquisitions and then reconstructing it together. The reason you can do this now is because, again, improvements in computer technology, which allows for parallel imaging. So to do this, the workflow for this is not straightforward and simple. The images actually come off the scanner. They get pushed to a third-party workstation that then reconstructs the images. That has a lot of parallel GPUs and then pushes the images back. But I think at least there's this is something I think we'll be able to do in the future. Now, one of the things I'll talk about is, not even going to that sophisticated of a level. One of the things is now that as there's these newer MRI scanners that have what we call high-density coils. So instead of having just a few coils, there's a myriad of coil elements here. And so as a result, you can use a technique called parallel imaging, where you look for differences that one coil sees versus another coil and use that to fill in missing information. And so this is an example of a real-time cine acquisition that we did on our scanners, which for this level of resolution, if you're doing this in real time, you're only able to achieve about 7 frames per second. But now when we go to what we call a two-fold acceleration, where we only sample half the data and then filling the other half of the missing data just based on differences that the different coil elements are able to sense, you're now able to get fairly comparable image quality, but now you're getting 14 frames per second instead of 7 frames a second. If you go to threefold acceleration, you now are able to go to 21 frames per second. And then lastly, if we go to a fourfold acceleration, we're actually able to get to about 27 or 28 frames per second. So you're getting much higher temporal resolution. If you want, you can trade this off to get higher spatial resolution, whatever you want. You'll notice that the SNR goes down a little bit, but again, because of this high density coil sampling techniques, you don't really have that much of a loss. And so again, this allows you to either do the acquisition in a shorter period of time or to get higher spatial or temporal resolution, whatever it is that you choose to do. Okay, so let's also touch on, valvular heart disease obviously is an application that we do quite a bit. And there was a recent update to the American Society of Echo guidelines that talked about the role of echocardiography for assessment of native valvular regurgitation. But there's also now a segment in there with regard to the role of CMR. And so this actually was a joint document that was done both by the ASE as well as the SCMR. And I think what it nicely kind of highlights is, if you look at scenarios where all the parameters line up, and this is just an example of the algorithm for mitral regurgitation, if you have all the criteria that are specific for mild MR, I think the answer is straightforward and clear. If you have all the criteria that are specific for severe MR, the answer is pretty straightforward and clear, there's severe MR. But there's certain scenarios in which things are not so clear, and those are cases where quantitation may be useful. And some of the examples where CMR is recommended in this, and I'll just kind of give you a high-level overview, is obviously if you have technically difficult transthoracic echo images, as is shown here. So if you can't see it very well, that might be a role for proceeding on to a test like CMR. Also, when there's a discordance between your history, your physical exam, and your 2D and Doppler findings. So if you have a loud murmur of MR with a diastolic rumble suggesting it's severe MR, but you don't see much MR on the echo, that's a clue that you may want to move on to CMR. Another example is if you've got, what looks like severe MR on your echo, but your LV size is completely normal, that, again, could raise suspicion that there may be some discordance here, and those are scenarios where CMR may be useful. The other scenario that's highlighted is when you have very eccentric jets, where it can be hard to identify an accurate vena contracta or a PISA measurement. Those are scenarios where CMR could be useful. And then also in the scenario where you have non-holosystolic mitral regurgitation jets. So as is shown in this example, TE here, where you have mitral valve prolapse, you'll notice the leaflets coapt, or they begin to come together, and in early systole, you really don't have any regurgitation, and then all of a sudden, in late systole, you have a huge amount of regurgitation. And the question is, what's the overall amount of regurgitation that's occurring throughout this cardiac cycle or throughout systole? And MR, because it's a volumetric-based methodology, it just simply gives you an integral of the total amount of regurgitation that occurs throughout each systolic phase. And then also, I think it calls out scenarios where there's multiple jets, where you have both mitral regurg and aortic regurgitation, where it can oftentimes be hard to quantify the severity by echocardiography. And then lastly, in situations where you need, or there's a question about what the remodeling of the ventricle is. So, you know, when you need to look to see, is the left atrium dilated, is the LV dilated, is there LV dysfunction, and the echo is suboptimal or equivocal. Those are scenarios where CMR can be useful as well. And then lastly, I think it's in the setting where you're looking for myocardial viability or scar, CMR, obviously, as we touched on, is very optimal for that role. So these are just some of the algorithms for aortic regurgitation. Let me just skip past this in the interest of time. Go to this next one. So the other thing I want to touch on is what about you know, patients who have renal failure. So, you know, one of the things that we've known is that since 2007, 2008, when there was this FDA advisory that came out with regard to using gadolinium agents in patients with renal failure, because of this condition called nephrogenic systemic fibrosis. This can be a very life-threatening condition where they get fibrosis deposition in the skin, in the joints, as well as in the organs. And initially, when the advisory first came out, it really kind of put a caution for anybody with a GFR less than 60. Because when they looked at the initial reported cases, there were some people with GFRs in the 40s and 50s. But then, as they dug into this further, they realized that, you know, those are all cases where there wasn't really a creatinine that was checked any time within close vicinity to the MRI scan. And so the criteria that were modified to say basically patients with acute or chronic renal insufficiency with a GFR less than 30, those are people that you worried about, as well as people who had hepatorenal syndrome, who are in the perioperative phase of a liver transplant. And it really recommended that all patients should be screened for liver dysfunction. And then there was an update to these in 2010, which really identified that the highest risk group was those with a chronic GFR of less than 30, those who had gotten repeated doses of gadolinium contrast. And furthermore, I think that there was really no risk in people with normal kidney function. And therefore, you know, the screening algorithms were altered as well, not to say that all patients necessarily need to get lab testing, but all patients need to at least get some evaluation based on either history or lab testing to look for the presence of renal dysfunction. But what that did leave, though, was really that if you had a chronic GFR less than 30, you really couldn't get gadolinium-based contrast agents. So there was really no option for these patients. And we know that a lot of these patients, CT is also limited. You know, if they're not on dialysis, then iodinated contrast is also an issue, and X-ray contrast is also an issue as well. And so the question came about, well, what do you do for vascular imaging for this group of patients? And so for a while there, people were using these time-of-flight MRA techniques where you're basically, it's a non-contrast acquisition, but you can see the image quality here isn't really phenomenal. And some of the challenges with this technique is that slow flow or flow that's not perpendicular to the direction of imaging can mimic a stenosis. And so that's when, you know, about 2010 or 2009, after the FDA had approved this intravenous agent called ferumoxytol, which is an iron agent, which actually is indicated, you know, its approval is for treatment of iron deficiency anemia in patients who have renal failure. But what's interesting is that this agent also has ferromagnetic properties in the vascular system, so you can actually use it for vascular enhancement. And I think what was different about ferromoxetol compared to older iron preparations was that the amount of free iron was very little, so you could actually give it as a very rapid injection. In the past, most of the iron agents or iron preparations that were around had to be given as a very slow intravenous infusion because the amount of free iron was higher, and therefore there were issues with tolerability. And so, when this agent came to market, came to approval for, again, iron deficiency anemia treatment, we noticed it's also useful for vascular imaging, and we began using it as an intravenous contrast agent in patients that are needing vascular MRA. And if I show you two example cases here, one done with gadolinium and one done with ferromoxetol, I think we'd have a hard time identifying which is which. And I think this just kind of highlights the fact that the image quality that you get here with this iron-based agent is really as good as what you could get with gadolinium. The big key difference, obviously, is that with the iron agent, you can give this safely in patients who have renal failure. I think that the kind of take-home message now is, at least for vascular imaging, there's no longer a contraindication to being able to perform contrast-enhanced MRA with the use of an iron-based agent. Now, again, the properties of ferromoxetol, though, are not such that you can use it for scar imaging. So it's not useful for cardiac imaging to look at myocardial viability in scar, because it's not an extracellular agent. It's actually an intravascular agent for several days. But at least for vascular imaging, it can be useful. Now, the other, I think, limitation with MRI had been patients with implanted devices, right? And there's really kind of a series of concerns with these patients. One is with regard to the lead heating. So the device leads could actually heat. And most of that is thought to be due to the radiofrequency energy that's applied when you do your MRI imaging. There's also a concern for unintended cardiac stimulation. And again, this was due to both the RF pulses that are applied as well as the gradients that are switched on and off. And then lastly, there was a concern for device interactions that are thought to be due to both the static magnetic field, due to the gradients, as well as the RF. And the concern could be that could there be pacemaker malfunction or failure that may affect pacing therapy. So for a long time, for many, many years, patients with devices did not get MRI scanning. As you can see, though, this is not an inconsequential issue, because this is some data looking at what is the incidence of a patient needing to get a diagnostic MRI after they've had an implant put in. And you can see over time, especially as 2 years out, as many as 1 in 5 patients who have a device put in will actually have an indication to have an MRI scan done. But again, they couldn't in the past. And so obviously industry was hard at work trying to solve these problems. And so in 2011, there was a device called the Medtronic Revo device that was the first device approved in the US that was what we call MRI conditional. And it was both a pacemaker as well as a set of device leads that had been tested, and had been tested in this multi-center study, which was published in the Heart Rhythm Journal, of 464 patients who underwent placement of this device, so the pacemaker as well as the specific leads. And then the patients were then randomized, half of them to receive an elective MRI and half to receive no MRI at approximately 2 to 3 months after the device placement. And then they went through and looked at what was the incidence of complications, and they found that in the half that got the MRI, a little over 200 patients, there were no incidence of complications. There were no episodes of sustained ventricular tachyarrhythmias, no episodes of asystole, no episodes of pacemaker output inhibition, and no episodes of electrical resets that occurred. But they did notice some minimal changes in the pacing capture thresholds. And so I think that's what, that study is what led to the FDA approval for this device. And so I think it certainly had helped for patients in the future that were getting this device put in, but it didn't do anything about all those patients that had devices put in prior to this device coming to market, prior to 2011. Didn't do anything about defibrillators. And also the initial device that was approved also was limited to non-thoracic scans. So it was limited basically to above the sternum or below the diaphragm. And so Medtronic then followed up a couple years later with a second generation device called the Advisa, which also looked at thoracic scanning as well. So that limitation was now removed. So there was no longer the limitation of non-thoracic scans. But again, the first two issues still had not been eliminated yet. And then in 2015, Biotronic came out with another MRI-compatible pacemaker, and they also had a MRI-compatible ICD as well. And then in addition to that, Medtronic also came out with an MRI conditional ICD in 2015. So I think that checked off these two, the thoracic scan limitation as well as the defibrillator issue. Those issues were eliminated. But again, it did eliminate this question of all these people who had devices put in before this time period. So that's when there was a study, this is really a study of multiple folks within the MRI community with a little bit of support from Device that put together a 1,500 patient study that we were involved with as well, looking at patients with non-MRI conditional pacemakers and defibrillators and looking at can these patients be done safely. Now the key here obviously is there's a very specific protocol that was utilized for interrogation of the device before the procedure, reprogramming of the device for the procedure, and then follow-up of the device after the procedure was done. And in this, and this was published in the New England Journal just earlier this year, really there were no cases of any major complications. There were no deaths in these 1,500 cases, and it's broken down between 1,000 pacemakers and 1,000 ICD, or 500 ICDs for the total 1,500. There was one case of a generator failed in the ICD group, but when they went back and looked at the history, that actually was not programmed correctly. Whatever the site that was enrolled that patient had not deactivated anti-tachycardia therapy. There were no cases of lead failure requiring immediate lead replacement, no cases of loss of capture during the MRI examination. There were some observed atrial arrhythmias, and again, that's just a function of the underlying rhythm abnormalities that these patients can have. And there were a few cases of electrical resets, which means that the device reset. And so that's why, again, I think the kind of conclusion of this, and then this also goes through and shows the magnitude of changes that occurred in device parameters. And again, the key point of that was that there were some small changes in device parameters that occurred, but again, nothing that led to the need for putting a new device in. And so I think the general conclusion here was that using, and again, this was limited to non-thoracic scans, but these were non-MRI approved devices. Again, this was done at 1.5 Tesla, that using a pre-specified protocol at 1.5 Tesla with patients that are appropriately screened, devices that are appropriately reprogrammed, it was done safely in a large cohort of patients without significant device malfunction or without significant adverse events. And so I think, that certainly, I hope will change the paradigm in the future, which is that for all these patients that are out there without these newer devices, there at least may be an option to do this. Now, one of the things that I want to caution everybody on is, the take-home message, I think, from that MagnaSafe study that we did is not that you can just go out and start scanning everybody now with devices. And the reason is that, I'm going to segue a little bit to this kind of interesting thing for anybody who's been to Las Vegas. I'm sure you've seen that the Vdara Hotel. So it's kind of an interesting...
Thinking of taking a road trip to Vegas, be warned. The new MGM hotel there called the Vdara has been found to contain an extra you definitely don't want. It turns out when the sun's rays hit that curved building, it creates a 15-foot wide hotspot on the ground that is so brutal it can burn hair and skin and even melt plastic. Some unlucky hotel guests have been sent running from the pool area after being caught in what hotel employees are calling the death ray, a burning sensation from above. The hotel is rushing to fix the problem.
Okay, so what happened there? I mean, the issue there is, you've got obviously, when you're building a multi-billion-dollar building like that, you're going to have extensive engineering testing and things done, but just the way that the curvature of those windows, that building has a lot of windows, the curvature was such that during a certain few days of the year, during a couple hours within that day, the sun rays all kind of concentrate down into one area of the pool. And I think, the point of this is that MRI has nothing to do with Las Vegas or with buildings, but the idea is that this is why also, if you look at the MRI terminology that we utilize, we use a term called MRI safe, which is really something that has no known hazards in any MRI environment. All these new MRI pacemakers and defibrillators are not called MRI safe. They're called MRI conditional. The only thing that will be MRI safe is something that's completely non-magnetic, like a Petri dish, okay? Most of these newer devices are what we call MRI conditional, which means that there's no known hazards in a specified MRI imaging environment with specified conditions of use. And because the issue is that in any possible permutation, there's always a possibility that you could have something that's untoward that can occur, just like what happened at that hotel in Las Vegas. And you may go 500, 1,000, 10,000 times and not have it happen, but it may happen with just everything lines up a certain way. And so I think that the take-home message is you should not be able to think that, yes, you can now just scan everybody with devices. What it means is that there's an acceptable risk profile, and that's why it's called MRI conditional, if it's done under a preset set of circumstances and done in a very careful manner. Okay, so let's move on now to kind of a couple of other newer technologies and newer applications. One obviously is this new technique called 4D flow imaging. So, what we typically have utilized is what we call 2D phase contrast, which is similar to your echo Doppler, which again gives you just a two-dimensional assessment. This 4D flow technique now, the reason it's called 4D flow is because you have X, Y, and Z. So you have a three-dimensional volume and you have it over time. So you're actually able to generate velocity vectors in any given direction. And so you can use this to not only identify flow within a given vessel, but you can also use it to actually look at the pattern of flow, look at swirling of flow, and a variety of different things. This is one of those things that, I think we're still getting a full grasp of what all it can do and how it can be useful. So I think this has opened up potentially a whole new line of investigations. And show you some example cases here in aortic dissections where you can actually use this to help identify the presence of a reentry tear with retrograde flow into the false lumen that sometimes you may not be able to see just on standard 2D imaging. It can also be used to look at the pattern of flow. It can also be used to try to measure flow within the mesenterics. Because once you have that full 3D volume, you can then simply offline place a imaging plane right here perpendicular to the vessel, and you can try to measure how much flow is coming into this celiac or SMA. So it's a lot of new applications that it can open up. But again, I think this is one of those things that we're still learning what the full role of this is. So let me skip past. Another area I think where we may see some work in the future is in the area of taking MRI out of the purely diagnostic arena and into an interventional arena. And we actually have here two of these labs set up. One is over on the second floor main building, where there's an MRI scanner, and next to it there's a X-ray angio suite with these doors that can open and a table that can actually transport back and forth. And we also have this in a research scanner in the Mighty building on the 5th floor, a very similar setup, so we can actually take animals in the Mighty building, do an angio on them, do whatever procedures or maneuvers you want, and then wheel them over to the MRI. And so this is some work that Huey Lin is working on with us, right now mainly in animals, but the idea is eventually to be able to try to transition this to human work as well. Kind of a pie in the sky idea, and this is one of the things that we're working on with a National Science Foundation grant with some engineers from University of Houston, is actually be able to use MRI not only to image, to generate images, but actually to use the images to identify landmarks to then generate what's a corridor of safety. So if you're doing, let's say, a TAVR procedure, and in this example here, if you're going in through a transapical approach, by obtaining real-time images, you can actually identify what's a safe corridor that your catheter can be in versus what's an area your catheter shouldn't be in. And then in this example here, it's a robotic interface, a robot that's actually used while the patient's inside the scanner, because obviously it's hard to get access to the patient's groin when they're inside the scanner. And so the robot with multiple degrees of freedom could actually then be manipulated under MRI guidance to be able to position devices, to be able to do biopsies of a variety of different things. And again, I mean, these are not things that you're going to see come into clinical practice in the next year or two. These are things that are probably a 10-year horizon. And then let's get past. And then, so I think that to kind of wrap it up, I think we're really looking at, the advances, I think, in CMR over the last 10 or 15 years have really made the assessment of myocardial fibrosis very robust, both from the standpoint of replacement fibrosis and now with use of dark blood techniques looking at papillary muscle fibrosis, but also now with ECV techniques where we can actually look at diffuse interstitial fibrosis. I think newer MRI contrast agents have eliminated the issue of gadolinium concerns and renal failure in patients who are needing vascular imaging. I think the issue of MRI with devices has at least been partially overcome. Again, with using a careful approach, most patients with devices can in fact be imaged now. And then lastly, I think the area that we're hopefully going to see in the future are areas of faster imaging to the point where we can actually use MRI as a guidance tool for doing interventions in the future. So thank you for your attention and open up to any questions. Any questions? No? Okay. All right, thanks.